The following video is from the University of Louisville Department of Orthopedic Surgery. We describe an all-soft tissue meniscus allograft transplantation with circumferential suture tape augmentation to mitigate hoop stress and promote centralization.
The authors have no conflicts of interest to report. Graft preparation is performed with an age-limited and size-matched, fresh, viable proximal tibia allograft. The authors have utilized this technique for both medial and lateral meniscus transplants. 3 total fiber tape sutures are utilized, but any commercially available suture tape of equivalent size and strength would be suitable. The first suture tape is used to create a modified Mason-Allen stitch at the apex of the anterior horn of the meniscus. One limb of the first tape is left exiting the apex of the anterior horn. The other limb of the first suture tape is coursed through the meniscus periphery to create an internal brace structure. This other limb of the first suture tape exits the apex of the posterior horn. A second suture tape is looped around the now formed peripheral internal brace at the posterior 1/3 junction of the meniscus. Lastly, a third suture tape is used to create another modified Mason-Allen stitch at the posterior horn. Note that a peripheral circumferential internal brace with 3 points of suture tape fixation has now been created. The first suture tape is at the anterior horn with 1 exiting limb for fixation. The second at the posterior 1/3 junction with 2 exiting limbs for fixation. And the third at the posterior horn with 3 limbs exiting for fixation. Also note the second point of fixation with 2 exiting limbs of suture tape wrapped around the internal brace at the posterior 1/3 junction has the capacity for approximately 1.5 to 2 centimeters of translation around the internal brace construct. This is a critical element as it allows for proper graft positioning once introduced into the joint. A static point of fixation at this site could cause graft bunching should its drill tunnel not perfectly align during meniscal seating. The eventual tensioning of each of these 3 points will recreate a circumferential force through the internal brace, mimicking the circumferential collagen fibers in a load-sharing manner. Subsequently, this provides a collective force that resists hoop stresses and therefore extrusion, as illustrated in this free body diagram. A standard diagnostic knee arthroscopy with meniscal remnant debridement is performed. To assist with posterior visualization, a few millimeters of the medial or lateral tibial spine can be removed with a burr. After careful identification of the root insertion, a drill guide is used in conjunction with a flip cutter to create a 6 by 15 millimeter inside-out socket in the tibia at the site of the posterior root attachment. Passing sutures are introduced. A drill guide and flip cutter at its most narrow setting is used at the posterior 1/3 junction. This site will be used for passing sutures only and not the introduction of tissue. First, the posterior root and posterior 1/3 junction passing sutures are used to shuttle the posterior horn of the meniscus into position. Posterior root meniscal tissue is then dunked into its 6 by 15 millimeter tunnel. Once the posterior horn is provisionally seated, approximately 3 to 4 inside-out meniscus sutures are applied sequentially from posterior to anterior. The anterior root attachment site is identified and a socket for a 5.5 millimeter peak swivel lock anchor is drilled prior to introduction of the anchor with the anterior root suture for anterior horn fixation. 2 to 3 inside-out sutures are applied to achieve fixation of the anterior haft of the allograft meniscus. Lastly, the posterior horn sutures and posterior 1/3 junction sutures are either final tensioned and tied over a bone bridge at the anterior medial tibia, or fixed with suspensory fixation via suture buttons or a tightrope. This technique places an increased emphasis on peripheral hoop stress resistance recreation in the form of an internal brace. Additionally, the internal brace construct could theoretically be added to a bone plug or slot root fixation technique should a surgeon prefer bony root fixation. Here are references. Thank you for watching this video from the University of Louisville Department of Orthopedic Surgery.